So, diabetes mellitus in women, silent killer. Is it really a silent killer just among women, in both women and men, in neither? Let's have a look. This talk will be structured in differences, eventual differences in prevalence, comorbidities, complications, treatment, and just one slide of conclusions, because there are some differences that are relevant in terms of prognosis, and in terms of management, and in terms of results of management between men and women. It's obvious that I'm not a woman. Nobody's perfect, but I've been always involved in the women group of cardiologists in the Spanish Society of Cardiology. In fact, I was in the first meeting of the group. So let's talk about prevalence. If we trail the prevalence of obesity for example, in the US, we see that between 1994 and 2010, obesity has been increasing more and more and again, and all campaigns against obesity have failed completely. And diabetes mellitus is trailing obesity in about a decade. So whenever there is an increase in obesity, there will be an increase in diabetes mellitus. And then we can see then in the right panel about a 46%, there are about 382 million diabetic people in the world, but the risk is that about half of them, they are not aware of being diabetic, and therefore this is the first problem, diagnosis, and to be aware that I'm not diabetic. Then, if we take into account that traditionally diabetes mellitus has been associated with ischemic heart disease from the cardiac point of view, we can see then there is a lot of deaths among diabetic people that are attributable to cardiac problems. But now we are seeing that heart failure is rather the issue rather than ischemic heart disease, as we will see. Now, diabetes is increasing both for men and for women and all around the world. Why is this so? Because it is, as we said, there is an increase in obesity, and therefore, in the end, it will end up increasing prevalence of diabetes. And if we see in the left panel for men and in the right panel for women, we see that most of the countries have more than doubled the prevalence of diabetes during last 30 to 40 years. And only some countries, and mainly in women, they have diminished the prevalence of diabetic women. As we can see in light blue in the right panel, countries with high income Western countries, those are the ones that are maybe diminishing the prevalence of diabetes among women, not among men. So all in all, prevalence is at least the same, but usually is increasing and clearly increasing. And what about comorbidities? We can see that there are some differences between obesity between men and women. Usually among women there is more so-called healthy obesity, which is, well, it's been discussed. There have been several papers in the European Heart Journal about this so-called healthy obesity. But if so, it is more prevalent in women. Why? Because obesity is more subcutaneous rather than being visceral, as in men. But anyway, obesity is not a good thing to be if we have the choice of being lean. But anyway, there are some differences between men and women. There is differences in metabolism. There is more fatty liver among men. There is a decrease in androgens, whereas in women there is an increase. And there are different patterns of overweight and or obesity between both genders. And the last point in here, the risk in cardiovascular disease is especially relevant among women, as we will see. Now, diabetes mellitus, there is an NHS picture that is very useful from the epidemiologic point of view regarding deaths in the world. And diabetes is not a leading cause of death in the world. And why it is so? Because of this. Because type 2 diabetes usually is a merge of people with obesity or overweight, dyslipidemic, and hypertensive. And therefore, if we take into account hypertension, obesity, sedentarism, diet, and so on and so forth, dyslipidemia, diabetes by itself loses power and it's just falls from the equation. And this is important because the impact of cardiovascular risk factors in diabetic people is much higher than the impact that they will have in non-diabetic people, as we can see in red, when compared with blue. And what about complications? In here, we can see anything, but if anything, we can see that cardiovascular disease is more relevant in prognosis in women than in men. Stroke will be also more relevant among diabetic women than in men. And mortality probably will be also more associated with women rather than with men regarding mortality. And what about incident coronary artery disease? This is a meta-analysis where we can see that all along those epidemiological studies, we see that there is a 44% excess risk of incident coronary heart disease among women than in men. And this is for coronary death, for non-fatal myocardial infarction, and for all subtypes of stroke, both ischemic and hemorrhagic. The excess risk is always in the side of women rather than in men. And why is this so? Usually, risk factors are worse dealt among women than in men. And we see that being diabetic, you can see that there is an excess of blood pressure. It is higher among women than in men. Total cholesterol will be slightly higher also among women than in men. And triglycerides will be also higher, and HDL cholesterol will be lower among women than in men. Therefore, all risk factors are not dealt with the same quality between men and women. And this will have also consequences in treatment. So wherever we look, we see that there is an excess of risk among diabetic women regarding diabetic men, but this excess of risk is most obvious when we compare diabetic and non-diabetic women, because we will see that the latest works have been more specific about this issue in the last slides. So in this slide is one of the important slides, because among people with no type 2 diabetes, there is an adjusted risk between men and women of 2.4. Men have higher risk with no diabetes. But then, in diabetic women, when compared with diabetic men, this is exactly the same. The risk is exactly the same. Therefore, diabetes is a modifier that renders a much higher risk between women because they catch up the risk of men. Diabetic men have higher risk than non-diabetic men. And diabetic women have the same risk as diabetic men. But non-diabetic women have a lower risk than non-diabetic men. Therefore, diabetes in women increases the risk up not only more than non-diabetic women, but up to the risk of diabetic men. And therefore, this is the excess of risk of diabetes among women regarding coronary artery disease. Regarding peripheral artery disease, there is also, it is evident that whenever we have a diabetic patient with peripheral artery disease, the prognosis will be worse than otherwise. And this is more evident after amputation. And regarding gender issues about amputation and foot ulcers, we see that the risk is much higher among men than women, and regarding peripheral artery disease. But there is also a risk among women and diabetic women. And what about stroke? Stroke is one of the both hemorrhagic and ischemic, and this is mainly ischemic strokes. The excess of risk among women is clearly higher than among men. It's 27% excess of risk among women than in men. And what about heart failure? Heart failure, there is a cross relation between heart failure and diabetes and heart failure. Whenever there is a diabetic person, the risk will be much higher of having heart failure in the future. People with heart failure, the risk of having also diabetes will be higher as well. And diabetes and heart failure yields worse prognosis regarding heart failure. And this is more so in women, for women than for men, as it can be seen here. The prevalence of heart failure among diabetic women is much higher than among diabetic men. This is probably due to the relationship with other risk factors that are more heavily associated with women than with men, more hypertension, more age, about 5 to 10 years older. And this heart failure is, most of it is with preserved ejection fraction. And regarding prognosis of diabetes or non-diabetes, it is a relevant variable because both in preserved ejection fraction and in depressed and reduced ejection fraction, diabetic patients fare worse than otherwise. So there is an increase of heart failure. Heart failure and diabetes have a worse prognosis than otherwise. As I said, there is almost a twofold increase in mortality. And what about gender diabetes in the primary care setting? Usually, these are the cause of a British study in the primary care. There were about more than 150,000 people involved in this study, and followed up for 14 years. And we can see that overall, survival is rather similar. But this is primary care. I mean, from the primary care point of view. But there is an excess of death over 12% among women and 18%, 12% among men and 18% among women. So again, even in primary care, diabetes is worse in terms of prognosis among women than men. And going back to the concept that diabetes is a clear increaser of risk among women, is that whenever there is diabetes, the risk is rather similar for both men and women, whereas without diabetes, the risks are clearly different. It is worse for men than for women. And this is so for ischemic heart disease deaths and for major ischemic heart disease events. So again, diabetes increases clearly the risk among women to the point that equalizes the risk to men, whereas with no diabetes, ischemic heart disease is more risky for men than for women. And this is for all diabetes and for diabetes, type 1 diabetes. Lately, we are beginning to have the type 1 diabetic patients admitted in our wards, and usually because of myocardial infarctions. But those patients usually are obese or at least overweighted, and usually they are, despite being type 1 diabetics with insulin, obviously, as being obese, they have resistance to insulin, and they are also on metformin, being type 1 diabetes. And this resistance to insulin probably is what it also gives risk for developing great vessel disease and coronary artery disease and myocardial infarctions. So it is, so again, the higher risk for women, for both type 1 and for all types of diabetes. And in this slide that nothing can be seen, is basically to show that when we deal with all-cause mortality, the adjusted risk is 59% greater for diabetic males compared with non-diabetic, but it's an 85% greater for diabetic women compared with non-diabetic women. And this is, and this is so as well for cardiovascular mortality, specifically cardiovascular mortality. There is an excess of 50% for men, but of 145% in women. And here they're catching up. And for acute mortality, in acute myocardial infarction mortality, again, we see the same differences. So what about treatment? We see that diabetic women may have a clearly increased risk. And what about treatments? So well, once again, treatments are rather similar, but if anything, if there are any differences, the difference will be worse for women than for men, in the sense that there will be less lipid-lowering drugs, less aspirin for those with or without coronary heart disease, and the goals of treatment will be worse for women than for men, in both for cholesterol, for glycated hemoglobin, and for blood pressure will be rather similar. But for management of diabetes and management of cholesterol, usually results will be worse for diabetic women than for diabetic men. And this, again, is the same study as before. In primary care setting, we can see that the density of treatment is less among women than in men, and there are statistical differences regarding antiplatelet drugs and lipid-lowering drugs. It is peculiar to have in mind that there is only an 18% among men and a 14% among women, diabetic women, treated with lipid-lowering drugs. And this is so having in the whole cohort, there was about 30% of patients that had already cardiovascular disease. So at least one could expect that at least about 30% of patients would have to be treated with those drugs. And there was only half of them that were treated. And we say, well, we are dealing badly with those patients, we have no time, there is inertia. Let's go to the clinical trials. In the EMPA-REG trial, for example, it's the EMPA-REG trial. In EMPA-REG trial, 99% of secondary prevention, there was only 76% of patients on statins, on lipid-lowering drugs. So to be positive, we have a big margin of benefit to enhance our clinical practice still, despite all the guidelines. So as conclusions, very simply, prevalence of type 2 diabetes is clearly increasing all around the world for both genders, trailing the obesity pandemic. Obesity will have implications for diabetes, for heart failure, for atrial fibrillation, for coronary heart disease. Type 2 diabetic women have a higher density of cardiovascular risk factors, obesity, hypercholesterolemia, hypertension. Type 2 diabetes in women yields a higher cardiovascular risk than in men when compared with a non-type 2 diabetes population. Prognosis of type 2 diabetes is similar to that of men, which in relative terms gives a much higher risk for women than for men. And type 2 diabetes still receive less evidence-based, type 2 diabetic women still receive less evidence-based treatments, mostly statins, ACE inhibitors, and antiplatelet when to be considered. And that's it. Thank you.